Good morning. We're here to talk to you today about some exciting work about the future, and actually it's now. I'm Marilyn Rance. I'm a professor at the University of Missouri.
And I'm Marge Skubik. I'm a professor at the University of Missouri. Marilyn's in nursing. I'm in engineering.
So we're here to talk about some exciting work with technology to help healthcare providers detect illnesses earlier and detect those changes in condition that are often really hard for those of us working in long-term care and in people's homes to understand, gee, something's going on and we need to get somebody some health care now and intervene now. I'm a nurse, and our project is Aging in Place. And at the University of Missouri, what happened is a group of us were together in 1996, and we decided at an American Academy of Nursing meeting that we needed to do a wonderful new project and try to change the way long-term care is delivered in our country. So we got a group together, and this is our vision. And this was our vision at that time, and it continues to be our vision, that what we really want to do is dramatically change the way long-term care is provided, and we use proactive health care. The foundation for the work is actually RN care coordination and community case management. We know from a lot of the research that if older adults are care coordinated by a registered nurse, they'll get the right services at the right time, healthcare costs go down, and they have better clinical outcomes. We also had hoped that we would have educational and research opportunities that would evolve from the Aging in Place project. So as I said, this started in 1996, so I'm getting quite old, and this is, so I'm going to be well prepared and well positioned to participate in this project as a person rather than as one who helped to guide it in its beginning. So what our group actually did is we wrote a grant for the Centers for Medicare and Medicaid, and we were awarded that in 1999, and that ran for 4 years. And we had originally envisioned that we would be able to build an ideal housing environment in which to test the ideas of aging in place. But that didn't work out that way. You know, things that doesn't always happen. So what happened was that we tested it first in the community because we hadn't found the right partner to build the ideal housing environment for aging in place. So we started the test in the community by generating, by forming and developing a home health agency in 1999. And that we provided Medicare services, Medicaid services, private insurance, private pay, and over 100 people were served every month in this agency. So over those 4-year periods, we served lots and lots of people. Several hundred people were served during that time, actually close to 2,000 people over that period of time were served. And we evaluated that, and we learned some things that I'll explain. It does save money, and nurse care coordination does work like the literature said it would. And we tested it first, as I said, in the home and in public housing, and it worked well. We passed legislation in Missouri in 1999 and then in 2001 that enabled the construction of Tiger Place. And it's an ideal housing environment, so we could test aging in place within an ideal setting. So we opened Tiger Place in 2004 because with that legislation, we were able to do that. And it expanded in 2009 and in 2011. We served every day about 65 people in the housing development, and about 85 people now in our skilled neighborhoods. So these are the actual key clinical and financial outcomes and that we measured in this Aging in Place project. both in the community and then later at Tiger Place. So within the community, we know the cost savings were well over $1,500 per month with a nursing home comparison group. And in the community comparison group, almost $500 a month. That was within the community. In Tiger Place, what we've learned is that people who live there through the end of life, because that's the concept of aging in place, the total cost of living there and the care received there is much less than nursing home care, because as people develop clinical problems, we put services such as assistance with daily living and med management and services for them, but we help them regain their function and we pull those services back away. So their care bill constantly goes up and down, so that even through the end of life, they don't approach the cost of nursing home care. And they stay functionally active longer. So all of our clinical and cost outcomes are explained on our website. We have two very good websites at www.agingmo.com and also on our eldertech.missouri.edu website, the engineering papers. So all of those are there for you. We've published all of our results so that everybody can learn from this, and you can do it in your state or take pieces of it that work well for you, and learn from what we've done. So let me talk a little bit about Tiger Place. So these are some pictures of Tiger Place. It's a lovely place. It's very nice, and you have your own private apartment. You have an entrance from the inside of the building. You also have an entrance from the outside of the building, because everybody has their own private screened-in porch. So these are some of the pictures, and our partner is AmeriCare Systems, Inc. They actually built the building, and the School of Nursing operates the care delivery. So that's a collaboration and an affiliation that works really well together. So Tiger was designed to promote independence and aging in place with RN care coordination is the key. It's actually, for those of you in other states, you might want to think about this and talking to your state legislators or to your regulators. What we actually did, and I think would work quite well in other locations, is the building itself is built to nursing home standards. It's actually licensed as an intermediate care facility, so many people will use their long-term care insurance, so that what happens is about a third of the people who live there actually have long-term care insurance, and as they qualify for using their long-term care insurance, it pays for living there and it pays for the care, depending upon your policy. But it's built to nursing home standards. It's actually licensed as independent or as intermediate care, so you can use your long-term care insurance. But it's operated as independent housing with services. So it doesn't look like a nursing home, it doesn't function like a nursing home, but people can get services wrapped around them. We bring in hospice at the end of life, so you can live there through the end of life. As I said before, 31 apartments opened in 2004. We opened 23 more in 2009, and then in 2011, we have a skilled facility with 5 different neighborhoods, mostly focused on skilled rehab, and that was really, really helpful for our community. So our services, basically people, because it's independent housing, they have services, everything is paid for with a monthly rent. Housekeeping, transportation, 2 meals a day, social activities, as well as the health promotion activities. Everybody gets the health promotion activities, and that's part of the care package that everybody receives as living there, and that's part built into the rent of Tiger Place, and people can't opt out of that, as well as they can't opt out when they do need care. And our health promotion activities through our Sinclair Home Care, our exercise classes in ongoing nursing assessment. We have a wellness center that's open actually 7 days a week with healthcare staff there, but nurse and nurse care coordinator is there 5 days a week, full-time, There's an RN, nurse care coordinator, a part-time RN, as well as a full-time LPN who works with med management. And we have an RN care coordinator on call 7 days a week, 24 hours a day, so that as issues arise, they can be dealt with. So as I said, this was to be a new model of care of what people want and need, and it to be a collaborative research environment. So that we really wanted to create new solutions to those nagging problems. You know, I've been a nurse now since 1970, and I'm getting old. So, and many of those problems that I see, that I saw in 1970 for older adults are persistent. Those are persistent problems with losing physical function, losing your ability to do certain activities, and changes in nutrition, changes in hydration, problems with physical activities, and health problems. So all of those things continue to be a problem, and what we wanted to do was to find some new solutions to those problems and help people be independent as possible, fully engaged in life through the end of life. So, in about 2002, I went to the College of Engineering and gave a presentation to the College of Engineering faculty and said, come help us create new solutions to old problems. And Dr. Skubik raised her hand in that audience and said, hey, I'll work with you guys. This was our theoretical model that as a research team we started working with aging in place. And what we had imagined was that with aging, this is the typical trajectory of functional ability over time. And what we had hoped would happen with RN care coordination was to make those steps shallower and people more functional over time. And then, as we develop technology, we want those even more, those plateaus longer, the steps even more shallow. So this is our theoretical model for the development of technology to help people age in place. And I think this is really important. This is an important picture because our clinical staff could understand it and the engineers could too. And so we're doing this in proactive health management, integrating the sensor data and our health data. We look at behavior patterns by using in-home sensing, activity and gait patterns. Look for those changes. We can pick up early functional decline. We're sending automated health alerts, and we detect falls for early help and changes in fall risk. That's become very important in our work now, and RN care coordination to inform that. So, Dr. Skubik?
So this became a very useful joint model as we began to engage the engineers. When I look at this diagram, what I see is a problem in which we want to optimize the area under the curve in engineering terms. And in order to do that, what that means is that we need to have feedback. We need to know exactly what's happening in this situation. And that's where the sensors come into play. And so our hypothesis is if we can detect the beginning of that stair-step decline, or even better yet, predict when that decline is likely to occur, we can go in with an intervention and we can reduce that decline and make that line be straight. And so some people refer to this as squaring the life curve. So here's our mission, keeping older adults healthy, active, and independent. So our sensor network that we put together includes a number of sensors. We also have an electronic health record. We're looking for changes in the patterns that are collected by the sensor data, and that then becomes used in this automated health alert that Marilyn mentioned. We consider this whole system a clinical decision support system. So we generate these alerts automatically. They are sent to the clinical staff in the form of an email, because these are not the kind of alerts that demand immediate attention. These are generated on a daily basis, a 24-hour basis. They're sent to the clinical staff, and then they use them to inform their nursing care coordination, and they would then interact with the resident as needed in order to be able to address these interventions. So here's some pictures of some of the sensors. We use very simple, off-the-shelf, passive IR motion sensors. When we started this, we used a pneumatic bed sensor that was developed by some former collaborators that detects low, normal, and high pulse and low, normal, and high respiration, also captures restlessness. We have a stove temperature sensor that's used as well. And we put the motion sensors not only in places where they can capture the overall motion in a room, but we can also put them in the refrigerator to capture when someone's opened up the refrigerator, or in a kitchen cabinet, or over the shower if you want to see whether showering activity is taking place. And here's a layout. So this shows you a one-bedroom layout in Tiger Place. A typical one-bedroom apartment would have about a dozen motion sensors, a bed sensor, a stove temperature sensor, a computer that logs this data. And so we've been doing this now since October of 2005. We've installed almost 50 sensor networks in Tiger Place, and we've been able to keep the longevity of this going. So the average time that a sensor network has been installed there is well over 2 years. And that allows us then to see these continued patterns that are due to health changes that are occurring. We have a web interface that allows us to observe the sensor data and to quickly see exactly what's going on. It includes a number of different displays. This was something that was developed jointly with the clinical staff as well as the engineers and the computer scientists. This is designed to capture the general activity level. It uses these very simple off-the-shelf motion sensors. But the way these motion sensors are designed, they capture an event about every 7 seconds if there's continuous motion in the detection cone. We've found what we can do is process this data as a density, number of events per unit time, and that gives you a measure of whether somebody is leading a more sedentary lifestyle, where they're sitting very quietly, simply watching television or reading, as opposed to someone who's very active and moving around the environment, going from one room to the next. The way this is laid out, each column represents one day, and then the rows go from midnight at the top to 11 p.m. at the end. And then we have colors that give you the different levels of activity. So, and black represents times when they're out of the apartment. So this represents a very healthy, active resident at Tiger Place. And what you will tend to see here are black lines, black horizontal lines representing the time away from the apartment that may correspond to meal times when the resident goes to the joint dining room to eat. And here at the bottom, you actually see time that's in the evening hours. This started occurring after the phase 2 of Tiger Place opened up with the movie theater, and residents began to go see movies in the evening, and you began to see these blocks of time in the evening when they're out doing things. The colors then, as I said, represent the different level of activity. So white and gray is a very low level, yellow is a little bit higher level, green is higher, and blue is the highest level. What you'd like to see is the time at night be white or gray, that represent that a person is in bed sleeping very peacefully. They're not up and moving around. What you see in this particular person is that they tend to wake up at the same time every day. They tend to go to bed at the same time every day. They lead a very regular kind of lifestyle. And there's not a lot of motion at night, which indicates that the person is probably in bed. The bed sensor, of course, can be used to confirm that. You also tend to see these very consistent patterns. Some of our other patterns that we've seen with people that have cognitive issues, you might see a very irregular kind of pattern. But what we're really interested here is in looking for the changes in the patterns as they occur over time. So here's an example of how it might get used, and this particular person has a history of depression. So what's shown here are 3 different blocks of time, and you can see what happened here in the August 2009 segment, this person had depression, did tend to go out of the apartment. That's what you see here, these black regions that represent certainly the breakfast and the evening meal. They may choose to do lunch on their own and say they might not go to the common dining area for lunch. But it's not a very colorful chart in the sense that there's not actually a lot of activity while the person is in the apartment, except during very specific times of day. What happens in the later time period is that this person, after some personal losses, reported low energy, had trouble eating, and actually stopped going out to the dining room. And so you see this dramatic change where they're not leaving at all, if you look at this block period compared to this block period. There was an intervention that was made, and this person then received some treatment. And then you see the block in the third area there that shows an improvement in the activity level. So actually more activity, and again, they return to going out of the apartment for meal times as they were before. So alerts are sent to the clinicians to be able to alert the clinicians that there have been some changes made. And these are generated through a variety of different kinds of algorithms. And then the nurse would assess the resident and give them the appropriate care as necessary. Here's an example of what an alert looks like. We see here, and this is an actual alert that was generated. So we see here the time frame. This is all done using ID numbers because it's a research project. We do that for satisfying the IRB and preserving the privacy of the resident so that the researchers can look at them as well. But you can see here this is a nighttime alert that is generated. It shows you the parameter that was changed. In this case, there was an increase in bathroom activity. And this then includes a hot link to the sensor interface, so somebody can immediately click on that and the web interface opens up and they're immediately directed to the pertinent area that they can look at. We also capture feedback from the clinician, so there's another link to that area, and that allows us to capture a rating, 1 through 5, of whether or not this is a clinically relevant alert that was generated. And we do that for the purpose of capturing what the clinicians feel is a really good alert from their perspective. And that then is used as training data to further refine the alert algorithms. When we started out, nobody had generated any kind of health alerts. We didn't know what a good health alert looked like. We needed to have some way of capturing that. And so as we've continued to refine these algorithms, this now gives us a way of doing that kind of training process. We do add links to the electronic health record as well.
And if I was at Tiger Place, if I was the nurse at Tiger Place, I would be clicking on, after looking at the interface here, and I would check on the resident, and I could submit feedback about the database. I would click on this link and add a progress note to our electronic health record. We haven't implemented the electronic health record here at Western Homes Communities, but it is available for that. And that's what that looks like, and it's really quite convenient for the nurses at Tiger Place.
And in fact, we've taken some time now in linking up that electronic health record with the sensor data interface so that the two of them can be cross-linked to each other to make this a more efficient operation for the clinical staff. So this is one of the displays that you might see in that case where you have an increased bathroom activity at night. This happens to be for a different resident at Tiger Place where we were doing the study. And again, this is laid out the same way where you have each column representing one day, and then you've got the rows from midnight to 11 p.m. In this case, each of those red lines indicates time that a person was spending in the bathroom. And so what happened here was, you can see there was all of a sudden a change in the nighttime bathroom activity. As a result of this alert was automatically generated to the staff. And once they investigated, they found out that this was a urinary tract infection. So they, of course, had the person tested to see that that was the problem, and they were able to get the person care immediately before any more complicated problems arose. So this is a graph that shows the pneumatic bed sensor that we've been using in Tiger Place since 2005, and shows you some of the data that you can get out of this. So this is another instance of a resident, a 96-year-old woman, and you can see what happened in the changes to the sensor data patterns leading up to her emergency room visit and hospitalization, and then she died shortly after she was admitted to the hospital. What we found when we went back retrospectively and looked at this is that if we had had the alerts in place at this time, we would have generated an alert 40 days before the emergency room visit. 40 days before the visit. Now, who knows whether we would have been able to actually stop her ultimate ER visit and hospitalization, but we would have had a notification 40 days before the event. So we started looking at this in a little bit more, and we wanted to get more finely grained information about the bed. The nurses kept saying, we want the actual number. We don't want just low, normal, and high. We want an actual number that represents the pulse rate and a number that represents the respiration rate. And that started us working on a new bed sensor, which I'll show you in a minute.
Let me back up just a bit too, so that we explain to people. We've been working on this since we said 2005 we installed the first sensor network. So we had a grant at that time that was funded by the National Science Foundation and the AOA, the Administration on Aging, a federal source of funding. And we've written several other grants, lots of other NSF grants, and particularly NIH grants. We started doing the early illness work with NIH. So when we found how to develop these health alerts, that was actually funded by an NIH study. We put a group of clinicians together and a group of engineers. So we had a group of 5 or 6 nurses and physicians, and then the engineers working with us. And every week we would look at the data actually all week long. We sent some preliminary alerts out, setting preliminary parameters, and just the research team would get this. And then we would get together every week and say, well, let's adjust it this way, let's adjust it that way. And that really helped refine the system. But prior to our work with that, as we were getting ready to do the first testing of alerts, we actually went back through, we had a research person go back through 5 years of data and look at all of those information from all subjects and relate it to ER visits, hospitalizations, and falls. So we would draw a line on the sensor display of here's an ER visit, and then back up and look at what did all the sensor patterns look like. That's how we discovered the ones by retrospectively going back through several hundred of these situations that had occurred over the 5-year period. So that what we've developed is grounded in solid research funded by NIH, and we're really excited about that. So that then during the actual testing, prospectively for a whole year, as our staff at Tiger Place actually used the alerts, and for that year we discovered things like the urinary tract infections. We discovered pneumonia, upper respiratory systems, so that they got alerts before the ER visits, hospitalizations, and falls. And we found congestive heart failure, post-hospitalization pain, delirium, low blood sugar. Those were examples of the clinical diagnoses. So I think it's really important to point out that this is really medical diagnosis agnostic, meaning it doesn't matter what your diagnosis is, what kind of clinical health problem you've got. There's going to be a change in the sensor patterns that are picked up regardless of the type of if it's a heart condition, a kidney condition, a diabetes condition, a respiratory condition, you're going to pick up those changes in the overall sensor patterns. So we did these early illness studies, and it uses change detection. We also, during this study, compared an intervention group and a control group. So we had the intervention group that had sensors that they lived with, so that the nurse care coordinator got the early illness alerts that first year that alerts were used. And we had a control group, people living without living without sensors. And we measured a whole bunch of different things about them, as well as walking on the gait right mat and measuring different things with gait speed and physical function and a whole battery of instruments. And we found several pieces of these are relevant, so that the folks who lived with sensors actually were better, statistically better, than those living without sensors at the end of the year. That's really important in this pilot study. And now we have a larger scale study that we're hoping to conduct here at Western Homes, that we're just waiting for final word from NIH that will be a larger study. So we're collaborating with Western Homes, and this all started with a National Science Foundation study that Dr. Skubik is the PI, and we've installed in 15 apartments with 15 residents. Sensors have now been installed in their private apartments in this 100-year-old building. So we think that's pretty cool, that if people say, well, you can do this in a brand new building at Tiger Place where you planned for these kinds of activities to take place, the research activities to take place, but do you really have something that would work in my home or would work in my assisted living or facility? And actually we do, so that we've reduced the numbers of sensors, we've figured out which ones we really need. And so we're doing periodic measurement of walking, and we're also measuring grip strength to look at that intervention and control group here again. And at times, we also have the residents do what we call collection of ground truth, so that they'll put a sensor on their finger so we can measure their pulse and be able to check how well our bed sensor is working. And what we installed were motion sensors, the bed sensor, the Kinect, which the Kinect is the Microsoft Kinect's Xbox, and the gait we get from that information, and then our new bed sensor with pulse respiration and bed restlessness. So that's Western Homes Communities, and Dr. Skubik, I think you might have some more words to say about what we're actually deploying here.
The ballisticardiogram, I've included a chart of this too so you can see what that looks like. This represents one heartbeat of the ballisticardiogram. It kind of mirrors the electrocardiogram that many people have been used to seeing. The electrocardiogram, of course, is the electrical impulse of the heartbeat. The ballisticardiogram is the mechanical effect of the blood flowing through the body as a result of that electrical impulse. And so you get a signal that looks very similar to the ECG. So you can see here the motion of the respiration. So the high amplitude, low frequency signal is the respiration, the breathing. And the lower amplitude, higher frequency signal is the ballisticardiogram. And of course, with some clever signal processing software, you can automatically pick those out. What as we've continued to work on this, we've now got a system that uses these 4 transducers that are aligned vertically, and we place 4 of them across the bed. They go underneath the mattress, so they're completely non-invasive. We have the signal here that's including a ground truth signal. This would be from a finger sensor. We've done this to test out the bed sensor, where you have somebody put on a finger sensor to see what the heartbeat, what the pulse rate is. And so these represent each of the pulse rates, the heartbeats. And then you can see what these filtered signals look like. Once you filter out the respiration, you can see what the 4 transducers look like. Now, depending on which transducer somebody's actually lying on, you'll have either a clearer signal or a signal that looks a little bit noisier. But we've now figured out how to identify which is the best transducer signal to use for a particular 15-second segment. Here's what it looks like installed. This is actually a picture of one of the residents here at Western Home. And you can see the 4 transducers that are lying underneath the mattress. And we have a little embedded electronics box that is also included here. So these cables connect up to this box. And then that transfers data wirelessly to a computer that's situated in the apartment. So we now have 15 of these deployed here at Western Home. So here's an example of the kind of data that you can get from this. So we've shown here also the ground truth from a finger sensor that correlates to the heartbeat that comes from a hydraulic bed sensor. And you can see the little dots above each of those main peaks, that what's called the J peak of the ballistocardiogram, represent where the automated software identified a heartbeat. And you can see how it lines up with the ground truth that comes from the finger sensor. And you can, by identifying these individual beats, you can also capture the beat-to-beat interval. And now you can see here on the left, it shows the beat-to-beat intervals that you get over this time period from the hydraulic bed sensor versus what you get if you actually use this finger sensor. And they look pretty identical. So here's how it works. We've got this sensor box that's situated in Iowa, in Cedar Falls. It's transmitting data wirelessly to a small computer that's in the apartment. That's also collecting data from the motion sensors and from the Kinect. That gets sent then via the internet to a server that's located in Missouri, at the University of Missouri, where this data is saved, and we have some automated scripts that are running that are processing the data. So once this data goes into the server, now you can take a look at it using a web interface, and so you can investigate what that looks like. So here's an example of one of our residents. You can see the data that was collected. Now, the way this is shown here, we have an average that's represented as this middle line that's in gold. And then you can see, and these are done by daily averages first. And then you can see the minimum pulse rate that was generated for that day and the maximum pulse rate that was generated by that day. And then you can click on one of those days, and you can get an hour-by-hour average. And so again, you see the mean for that hour and the max for the hour and the min for the hour. And then if you click on it one more time on a particular hour, you can actually see the individual segments, 15-second segments, what the pulse was for each of those 15-minute segments. And it also tells you here in the bottom the time that the person was in bed. And so we know when we don't see pulse rates generated in that time period, that's because the person was out of bed. We can do the same thing with the respiration.
Okay, so this is the Kinect data, and we're really excited about this. We have two grants going simultaneously at the moment, one funded by the National Science Foundation, that Dr. Skubik's the PI, one funded by the AHRQ, the Agency for Healthcare Quality, that I'm the PI on, and they're both focused on assessing for fall risk and potentially fall detection. And so it's been fun to work on that for the last 3 years simultaneously, because the different sensors have come out during that period of time. And one of the things that the ARC grant was focused on radar, and we're still focusing on radar, but in addition to that, the Microsoft Kinect came out while these grants were in progress. And we adopted and tested the Microsoft Kinect also. So what we see here is a 3D image that you can identify the person walking, and it looks like a ghost. And that's very helpful so that people don't feel that they're being continuously videoed while they're in their living environment. But from that information, we can get, from that depth image, the signal processing can be done by the engineers, and we can get our walking speed, we can get stride time, stride length, step time, all of those important pieces of fall risk assessment.
Let me just point out that this is what we call a depth image. So we don't use RGB images, the color camera images. This is not streaming video. This is using what's called a depth image. So for each pixel in the image, you get a distance to the closest object. And there's software then that segments out the person so that you can see this shadowy. It becomes effectively a three-dimensional silhouette of the person as they're walking around the room. And that's then the piece, this three-dimensional silhouette that we pull out. That's the thing, that's the model that we use to construct these various parameters for gait. We validated everything in the lab using a marker-based motion capture system. We have a Vicon system. So that's a $150,000 piece of equipment. It's not very easily moved. It's certainly not something you could put in somebody's home very easily. But what we've found is that by using that Vicon system, that $150,000 piece of equipment, we can capture now these same parameters using the $150 Connect. And that's something we can put in the home. So here's a picture of it deployed in Tiger Place, where we've positioned it up close to the ceiling. We've tried to make this as non-invasive as possible. It does require a wired connection to a computer, and here the computer's located in this cabinet, which is installed above the refrigerator, and there's a little conduit that goes around that allows the wire to go to the computer that's in this cabinet. But it's all situated in a very non-invasive way, and we now have 10 Connects installed in Tiger Place, and then we have the 15 Connect systems that are installed in Cedar Falls. So this is an example of a two-resident tracking of gait. And this is also a case that's taken from Tiger Place, although we've been looking at ones from Cedar Falls as well. But this is an interesting case because here the husband is resident 1, and when this couple first moved into Tiger Place, he was relatively healthy. And they moved in there, I think, because of the wife and the fact that she has Parkinson's. And so she was on medication, and her Parkinson's was being managed. You can see that the gait patterns that are being pulled out, we have here on this slide showing the walking speed as well as the stride length and the stride time are fairly consistent. This line here that varies a lot is the number of walks per day, but that we've seen does naturally fluctuate from day to day. But the interesting thing here that we found is what happened to the husband. So we thought when he first moved in that he was relatively healthy, but as we're tracking him over time, what we're seeing is a decline in his walking speed. And in fact, his walking speed went down because his stride length went down. So what that means is he started taking shorter footsteps, which is consistent with cognitive decline. So this, in fact, became one of the first indicators of cognitive decline, which he was ultimately diagnosed with. This is, shows how the Connect is actually installed then in the scene. So this is, I think this is the slide that I showed you previously that had the 11 motion sensors in them. And this shows how the Connect is actually situated. We try to set this up so that, this is something we identified in the lab, is that we get a little bit better accuracy when we have walks that tend to be towards or away from the Connect. And so we try, as opposed to lateral movement. And so we tried to set up, install the Connects in the apartments in such a way that we can capture those longer walking paths. So this is something we were able to do in the Cedar Falls apartments as well. We went into the apartment, we sort of assessed what they looked like. We looked for natural walking paths, and we tried to set up the Connect in such a way that it would try to capture that. But this increases our chances of getting longer walking sequences that are more purposeful walks, as opposed to simply walking around as somebody might be puttering in a kitchen, for instance.
So along the way, what we've done with all of the work about sensor technology and technology in general with older people, we started always interviewing people and talking to them. In fact, we ran focus groups long before before Tiger Place was even built and before we started installing technology, because we needed to know what the older people think about it and would they be willing to live with it, and if so, under what conditions. And these are the things, this is a composite of what we've learned, so that people really do take ownership of their sensor data. The acceptance of technology is really based on perceived need. And in general, if it's non-invasive, people are really willing to accept and they feel more secure. They do care about how the technology looks. They want it to look nice, so they want to make sure that it's not, they don't really have to think about it. They want it to disappear into their environment as best as it can. And you want to make it as small and as unobtrusive as possible, and please don't make me wear anything. And the other interesting thing is they don't consider the images, the silhouette images, an invasion of privacy. And I can understand why that's the case, because we've similarly had that same result using it in the hospital. We've now started working in the hospital, and we've deployed 6 Connects for about 8 months now. Actually, we've got about 8 months of data in university hospitals at the University of Missouri. And I'm going to show you a video clip of what a fall looks like with that.
This is not a real patient because we didn't want anybody to get hurt. But this also represents the confidence. So this is a fall that was detected, and you can see when the image there turned red, that's an indication that he was on the ground, and in fact, this fall confidence goes up. And it's not just looking at whether he's on the ground, it's looking at how he gets onto the ground.
And the image itself and the use of it within the hospital setting has been reviewed by our IRB, our Institutional Review Board, and has had very favorable review. In the hospital setting, we are not using any protected health information. We're just using this for fall, actually to start seeing if we can detect the falls, and then when falls are detected, we can rewind the event with the nursing staff so that the nursing staff can analyze what actually happened during the fall and do quality improvement with that. And we'll start an automated rewind procedure to use for quality assurance, get that perfected well, and then go and start testing also our algorithms more on a larger sample for actual falls. So these are our interdisciplinary collaborators.
We have a number of people that represent different departments in the University of Missouri. You can see, computer science, electrical and computer engineering, nursing, medicine, and so forth. A lot of the clinical disciplines that are represented here as well. We have some new ones that were formed as well. We have a music professor that we're collaborating with for doing rehab. And here are our websites that Marilyn mentioned.
So you can find papers on the websites, as well as if you look on the Aging Mo website, we have several videos that are 2-3 minute videos that you may find helpful. So please feel free to use that in classes. You can go to the website, click on it, and show that to classes or have students do that, or in other locations. So it's agingmo.com, and we have all of our technical papers
And nursing papers.
And nursing
other,
papers,
yeah,
too.
other papers that are on the eldertech.missouri.edu website.
So you should be able to find everything that's been published about our work, access to that on those two websites. So we'd just like to say thank you. This has been, it's been fun to do, and we're delighted that we've had this opportunity to talk today about our sensor work.
So thank you.